Right.
Okay,
All right.
we're set.
Thanks, Wendy. Thanks so much. I really appreciate being able to talk with a lot of you. I know many of you. So a lot of this work kind of started at UAB. So a lot of it will be work that I was doing at UAB, and then some new things that I'm moving into. So I'm going to move quickly through a lot of different projects. It's kind of be two parts. And then we'll talk about some things I'm going into in the future and would love feedback at the end. Hopefully it'll lead for a lot of discussion, and I should have plenty of time for questions at the end. So I'm going to focus today on talking about the geographic disparities with cancer, and we'll focus on some more specific topic areas. So the concept of place-based health has become increasingly important in all healthcare delivery, you know, including cancer. So much so that the National Academy of Sciences estimates that the characteristics of a geographic location affect about as much as 50% of all health outcomes. And this obviously includes cancer. This is well represented in the Alcaraz framework that shows the structural inequities beginning from the inequities due to conditions all the way down to the consequences due to these inequities. And if we focus closely on the cancer continuum at the bottom of this framework, you can see that this is where the geographic disparities can really be compounded, right? So it's a cumulative effect over time, beginning with prevention and screening, diagnosis and staging, treatment, survivorship, and then ultimately mortality. So the first part of this talk, I'm going to talk specifically about rural disparities, and we call it in cancer the rural mortality penalty. And it's not that cancer mortality rates have been increasing in the rural population, it's that they're not declining at the same rate as those in the urban population. So much so that we see that urban rates declined about 1.2% versus about 0.68% in the rural population. And we expect that rural counties experience more than 35,000 additional deaths per year. And it's not just due to location. It's not just due to the rural designation. We know that it has more to do with faster improvements in an urban healthcare system. We have growing disparities in socioeconomic resources. There's increasing specialists in urban centers, and the disadvantage is compounded by poverty levels, educational achievement, and then lower individual median income. Those are just some examples. So I'm going to talk briefly about three studies that I was actually working on at UAB that were not actually directly designed to focus on the rural component, but started to allude to some of these disparities. And one of them, the first one I'm going to talk about is where we were looking at a group of colon cancer patients from the SEER Medicare population, which if many of you are familiar with is older adults in the Medicare population linked with the SEER Cancer Registry. And the interesting part of this study is that we wanted to look at how an early surgery might impact readmission and some poor outcomes. And the unique part of this study was that we defined early with respect to that it was too early in the sense that they did not receive the appropriate preoperative workup. So we found that in colon cancer patients who were in low income areas and rural areas had higher rates of readmission after an early elective surgery, and the risk was not mitigated by the pre-op workup. So in other populations, the risk was mitigated by having appropriate care, but in these low income areas, this was not mitigated. We followed this study up by trying to identify some of these higher risk patients. And we found that again, a colon cancer population, that patients in resource deprived areas with fewer hospitals, lower hospital bed numbers, and lower incomes, they were less likely to receive overall guideline concordant colon cancer care. There were some interesting findings related to some of the resources available in these regions where there was differing guideline concordance based on academic teaching hospitals versus non-teaching hospitals, and receipt of colonoscopies in some areas versus not. And then finally, we looked at in another study for breast cancer patients, we were looking, and again, Medicare beneficiaries, we were looking at whether consistent primary care access would help to decrease preventable hospitalizations as defined by the AHRQ. So hospitalizations that theoretically with good, primary care access they would be able to manage these chronic conditions and stay out of the hospital. And in this study, we ended up finding that while most Medicare beneficiaries had access to a PCP, over 90% of breast cancer patients, in that 10% that did not, the risk was significantly increased among those who were older, who were in the older age group, that were rural and from low income areas. Those were much more likely to end up with preventable hospitalizations. So we took a more strategic look at some of these breast cancer groups, and trying to really actually tackle the rural question in another study. And for this one, using SEER Medicare, we evaluated whether necessary healthcare utilization was able to, in the years following treatment, so not during treatment, but after, if that would actually mediate the relationship between rurality and socioeconomic status and mortality. And to do this, we looked at an effect decomposition approach. And for an effect decomposition, it is essentially allows you to look at mediating effects, but it allows for mediation and interaction. And it helps to quantify direct and indirect effects of geography. And in this case, we're defining that as urban and rural status combined with socioeconomic on the outcomes. And then it allows us to kind of identify some potential pathways. And in this case, our mediator was our physician visits, which we're calling as like a proxy for access to care. So we did establish that overall there was a 25 to 45% excess mortality risk among those who were in the rural high poverty group compared to those with urban low poverty. And this did depend on stage and comorbid condition level. With urban low poverty groups, we did find a mildly greater rate of primary care visits for all poverty levels of rural and others. So essentially, we did see that there was an increase in primary care visits for rural areas, and urban medium high poverty. And then in the first year after treatment, rural low poverty patients actually did have higher oncology visits compared to the urban group. Now, where we really start to see some substantial differences were in the non-oncology specialists. So your endocrinologists, your cardiologists, we saw substantially fewer non-oncology specialist visits, 25 to 30% less in rural areas. And that was across both low and high poverty, and 10% less in urban, medium, high poverty areas. So overall, we can see that the rural-urban status had an effect, but so did socioeconomic status. To further kind of understand how that may have played a role in mortality, we used the specialist access and specialist visits as our mediator. And what we ended up finding was that for early stage disease, a lack of non-oncology specialists accounted for 22 to 32% of the excess mortality risk. And this was even higher in the stage 4 disease. So what this kind of tells us is that non-oncology specialists do play a crucial role in managing comorbidities that may affect longer-term care. And then we see that this could help mitigate some of this rural mortality bias. So those were just 4 snapshot studies leading to a longer-term project that I'm currently still working on now in about, I think, year 4. About year 4. And they all informed the approach and sort of the questions that we're asking now. And in this grant, we're looking at rurality measurement. So how does the actual different definitions of rurality affect our mortality estimates, and then the subsequent policy decisions based on that? And then we wanted to look at the contextual factors as well. How do other contextual information about the area inform and contribute to the rural penalty that we see? And then as a third component, we conducted a cohort registry linkage with I'm sure many of you are familiar with it, UAB, the Regards cohort. We did this via the virtual pooled registry cancer linkage study with the NAACR. And the purpose of this was to allow for a multi-level evaluation, to allow us to look at both individual level factors alongside the contextual level factors. So in the first, we need to think about how rurality is defined. So the first piece of this. We know that the definition choice impacts which communities are classified as rural or urban, and it affects resource allocation. So there's multiple federal definitions. We have over 15 federal definitions, and there's a lot of common elements in each with population size and geographic variation, or that include population size and geographic isolation as measures. And the variation can create some challenges, right? So one of the more common ones is the rural-urban continuum codes. It's a 9-level classification. We see the National Center, Cancer Center for Health Statistics, the urban influence codes. The index for relative virality is actually a continuous scale that's provided by Purdue University that they have come up with. So these are just 4 examples. They were designed for different purposes, generally speaking, but they have similar in some contexts, and then they have different justifications for why they make their rural designations. To give an example, to show you how the maps lay out, if we were to look at the RUCC versus the IRR, and we actually see that the National Center for Health Statistics and the urban influence codes actually map perfectly on top of each other. So even though they have not different numbers of classification systems, ultimately their 3-level definition overlaps. But you can see there are some differences between the RUCC and the NCHS, and then especially the IRR, which definitely highlights more of a rural non-core population as opposed to emphasizing the definitions for an urban population. So if we're to look at these different virality definitions, how would this affect our mortality estimates? To do this, we looked at cancer mortality estimates across 4 of these county level rural definitions, and then we grouped cancers into 3 large categories. Those with screening recommendations, obesity-related cancers, and tobacco-related cancers. Those are the larger cancer groupings that we know are most impacted by rural designations. We compared the binary definitions, and those were largely reasonably consistent. We only saw a variation of 1% to 3%, so you could feel fairly confident that if you're using the binary groups that you would see relatively consistent results. When we move to the 3-level, this is where we start to see a wider variation with up to 7% differences within and across the groups. And we do note that those with screening recommendations experience the greatest classification variation. And also of note in this is that those with localized and regional disease also showed the largest differences. So we may not have large concerns about the most commonly used definitions in the binary, but we still may have some questions about what are the optimal cutoffs, right? So how are these cutoffs being defined about what is determined to be rural and what is determined to be urban or metro? And maybe there's some other better measure, maybe a continuous measure that can optimally capture the rural gradient. So in our next study, we looked to operationalize rurality and to see how it might be different if we were to change or move the needle on this. So in this, we basically pulled from the same cohort. We pulled the screening cohort because that was the cohort that showed the largest differences. And we did 1 testing cohort and 4 validation cohorts to test this in. We looked at 3 5-year survival models for each of the definitions that we saw. And we tested 3 different cut points, right? The established one, the one that's given to us by the literature or by the federal body that designed the measure. And then we looked at a data-driven cut point that using optimal survival time method. So using a survival modeling approach, we're able to select what might be a more optimal cut point for that definition. And then we treated each of them as continuous to see whether any of these would also change the cutoff level. And we use different evaluation metrics standard for judging some of these cut points. So essentially what we're looking to do is if we have this degree of rurality, let's say there's an established cut point at level 3 or 4, we're hypothesizing that it might be moved to a lower cut point, that rural may not be as rural as people, that it may actually be more towards the urban direction that might be more meaningful in terms of providing resources, that the risk may be worse. So this was largely true. This is actually mostly what we found. We did find that the data-driven thresholds consistently indicated that a lower rurality threshold than the established definitions. So for the RUCC, for example, the code 3, level 3, which is metro less than 250,000 population, they would move to a 1. So that would be then the rural cutoff at that point. And for the NCHS, it moves from a metropolitan statistical area of 3 to a 2. That would be the most meaningful in that case. And the IRR does also have a cutoff established from a 0.5 to a 0.3. So all of these kind of moved the estimates down lower. So that's largely what we saw. And the estimates differed by about 7 to 14% once we changed and added those cutoffs. So your rural risk increased by that much. When we use the continuous approach, you can see my very elegant drawing here. This is sort of what we're thinking might be the most informative, is thinking about how can we get to sort of an adaptive threshold, right? That it might be the most helpful for capturing a rural gradient. But it's very challenging for policy implementation. If we kind of have a constantly moving needle, it makes it very difficult to allocate resources. So maybe from a research perspective, this continuous use can be helpful. But from a policy perspective, it makes it very difficult. However, it does highlight that the need for some methodological consideration when you are looking at some of these definitions, or at least considering the fact that the definitions may not be clear cut, and kind of taking things at face value may not be the most comprehensive approach. And some of these current definitions may misclassify areas that really do experience rural challenges. So why are these very tedious analyses so important? Resource allocation, right? They're allocated all of these designations. This is how people get money. This is how counties get money. They're allocated based on, this is how the federal, state, and the health system are able to determine who needs these, any of these funding programs. This includes healthcare workforce incentive programs, infrastructure development grants, Medicare, Medicaid reimbursement adjustments, clinical trial recruitment opportunity requirements, and telehealth coverage policies. So again, it's important to note which categorizations we're using and how we're reporting all of this evidence consistently over time, because these are how policymakers are taking these things into consideration. So maybe we need to just be reevaluating them consistently and reporting whether major changes need to be done. All right, so the next step to this was then to actually try to isolate the rural effect. So how much of all of these mortality disparities are actually due to the rural designation versus the other contextual factors that I mentioned? So to do this, we use the same exact SEER population that we pulled from before. And in this case, we use the same three groupings. We elected to use the RUCC as our rural designation to be, and the established cut points to allow for comparability. So we did not move any cut points on this. So to capture socioeconomic status of the areas, we use the area deprivation adapted for county level analysis, and we categorize each area as low versus high deprivation based on the median value. So to look at this, we used a standardized mortality calculation, which is death due to primary cancer. And we looked at this by urban and rural status, and we adjusted each model for area deprivation, age, race, ethnicity, sex, and year of diagnosis. And we did stratified models by stage. The standardized survival model approaches have some advantages to some of our traditional approaches. They use the observed covariate distribution as opposed to just modeling the average. So it helps you to interpret the findings a little bit more usefully in like a causal inference framework, I should say. So from these models, we estimated the attributable fraction of rural-urban status, and we also looked at the ADI in terms of deprivation in different categories, right? So we looked at it alone, together, and then each of them separate. And then we quantified unique and combined contributions. And then finally, we wanted to look at some of these, what might be considered a discordant county, meaning we wanted to look at counties that deviated from what we would expect, right? So when we would expect a county with high, a high rural gradient plus high ADI, but they had a low mortality rate, we wanted to kind of start highlighting, trying to see where things are flipped, right? Like where might things be different than we would expect. And that's where we can start looking at factors that might be useful for future interventions or study. And we looked at some of the characteristics of these outlier counties. So very briefly, when we think about the attributable fraction, there's two ways to interpret it. We can think of it as the proportion of probability of death before time t that can be attributed to the joint effects of living in a rural high ADI area at baseline. So this is looking at the joint effects, or we can think of it as the proportion of the probability of death before time t that would be eliminated if all patients lived in an urban low ADI area at baseline. So what we ended up finding was that rurality actually had a very small um, attributable fraction by itself, independently 1%, right? So if we want to use one of those interpretation, we can say 1% of all cancer deaths were potentially avoidable if all patients resided in urban areas, right? We did see a stronger effect for localized disease and especially for screen detectable cancer. So that percentage went up higher, which kind of tracks, right? It makes sense. But in general, the average mortality probability for rural high ADI areas was 38%. Um, and just to give context, some of the so if 1% was for rural, when we did age, we looked at the attributable fraction of age, just to give you context, age contributed to about 30% of the attributable fraction, so how old someone was. When we look at these discordant counties, we did see that some urban counties actually showed higher than expected mortality. We saw that more than what we would expect from a positive rural area. So I highlighted some of these in yellow. These were urban counties that actually had higher mortality, of these 56 counties. And what we found was that they were actually rural counties by numbers, but they were adjacent to a metro area. So they wouldn't necessarily get the funding or the resources of a rural environment because they're classified as urban or metro, but they're experiencing the high mortality rates. So it suggests that our current definition may misclassify some of these urban counties that experience rural-like healthcare challenges. So I'm just going to touch on a few other studies that kind of took different approaches to looking at some of these geographic differences. We really wanted to try to understand more of these other contextual factors because clearly the rural by itself was not the driving factor in some of these population-based analyses. So in this next study, we looked at some of the other characteristics of a county and how it contributed to rural mortality. And to do this, we looked at the county health rankings in the overall SEER population, and we looked at the mediating characteristics of the individual domains of the county health rankings. And largely what we found is that using a latent class analysis, which allows us to group some of these county profiles together, we found that there's significant heterogeneity in cancer outcomes that are not explained by rurality alone. We do see that rural counties have some better than expected outcomes despite limited resources, and then some of the urban counties had worse than expected outcomes despite what would be perceived as infrastructure advantages. So we see a big variation that shows the importance of local healthcare delivery, community resources, and policy environments. And if you're familiar with the county health rankings at all, they have different domains that include things like clinical environment, physical environment. They have social structures. So there's a pretty broad domain breadth there that can capture. So it really highlights the need for more targeted interventions that may address specific local barriers as opposed to doing broad sweeping categorizations that then dictate funding. So in another study, we were working with, I worked with some of the trauma surgeons who were looking at whether rurality affected whether a patient's received elective versus non-elective or urgent cancer surgery. An observation that they would receive cancer patients that were ultimately diagnosed upon emergency surgery, right? They're coming in with gastrointestinal pain or distress, and then they end up with what ends up being a cancer-related surgery in an emergent setting. What we thought we would find with that rural patients would have a higher rate. That we did not find that. There was no difference in urban, rural, non-elective cancer surgery risk. However, we did see that our sort of highly vulnerable patients, Black patients and those in socially vulnerable index areas, high social vulnerability index areas, had really the higher risks relative to everyone else to having these emergent surgeries. We did see that county level variation accounted for about 3% of the total variation in non-elective surgery probability. What this does tell us though, oops, that skipped. One thing to note for this is that we do see we saw that fewer than 10% of the rural patients received treatment at a critical access hospital. So this kind of implied that a lot of these patients might have been rerouted, these critically ill patients, to larger centers. And then this kind of aligns with the concept of emergency general surgery deserts in rural areas, that there is not the capacity to complete these surgeries in that area. It's also of note that SEER Medicare rural population is predominantly white, and it just definitely limits our generalizability to certain other rural areas. In a similar study looking at some of the colon cancer surgery outcomes based on rural or urban status, this is the last one I'll talk about in this area. We focused on the colon cancer population receiving surgery, early stage 1 to 3, undergoing an elective surgery, and we were focusing on the surgical approach, complications, and overall survival. We looked at a multivariable regression and a mediation analysis to look at how these all might interplay together. We did find it an interesting finding with the surgical approach. And this was done by my mentee at BMC. She did a really nice job on this. She was interested in the minimally invasive surgery. She found that rural patients were 33% less likely to receive minimally invasive surgery compared to urban, and that the actual surgical approach did mediate almost a third of the rural-urban disparity in the postoperative complications. So we did find that rural patients had a higher complication rates, double the post-discharge reoperations, and they had lower one-year survival. And of note, the rural patients actually had fewer comorbidities and less emergent surgeries, but they had higher complication rates and lower survival following colon cancer surgery. So again, one of the arguments going in was that, well, the rural patients just must be sicker and, be more likely to have these extreme surgeries. And that just wasn't the case. So we do see that access to some of these more advanced procedures might play a role, right? So what this tells us that it's, there's a motivating factor for expanding rural MIS access, which could be training rural surgeons in MIS techniques, having the additional infrastructure or technology, or there's referral pathways to get to more specialized centers. We also want to expand post-discharge care, which is another project that she is currently working on in the discharge portion of this. So what happens to rural patients when they're discharged, and what is a better pathway for them? So what's next based on some of this load of rural-urban information? We're completing the Regards Cancer Registry linkage. We've sort of cut the data at this point, so we're working on looking at the multi-level component to this right now. We have about 5,000 participants from the 30,000 from Regards. And then I'm also going to be looking at healthcare experience and how that plays a role in some of these rural, and how that might play a role in the rural mortality penalty area, specifically in how it might play a role in the perception of receiving optimal treatment, cancer treatment. A lot of these are going to be focused on the localized and regional disease stages, as that's where we're seeing most of the difference. And then again, we're going to start using some alternative spatial methodologies, which I'm going to talk about very briefly in a second, and then I'm happy to discuss those further to make sure we get to the next piece. So I'll talk just a few considerations, because obviously the complexities of some of this geographic pieces are very real, right? There's a big risk of the ecologic fallacy, right? We're drawing individual level inferences from group level data. Requires very careful consideration in how we're interpreting that information. We have issues that are called the modifiable aerial unit problem. This is kind of what we're addressing, right, in the measurement piece. Results vary based on how the geographic areas are defined and aggregated. Spatial autocorrelation. Data points are not independent, right, if they're close together. So statistical methods, we'll talk about a few of these options in a second, that can account for some of these spatial dependencies. And then edge effects. So areas at the edge of specific regions may have incomplete neighborhood information, which may bias them towards just based on their cut points, right? So again, the measurement piece to this is very important. So some considerations when you're thinking about data sources in these areas that we're always trying to consider and are coming up in even the Regards cohort as we're working with that. There's geocoding challenges to all of this, and thinking about the timing relative to the disease course, and then thinking about the accuracy of data sources and geocoding match rates, and then historical address changes. When we think about the geographic data definitions, we have to think about are we using spatial coordinates? Are we using administrative units? Is it just contextual data? Is it not necessarily the actual place, but it's the contextual information linked to the place? Are you thinking about accessibility measures? Is it time or distance to healthcare resources? And then one of the largest issues we're running into now are privacy concerns, right? There's data granularity limitations, there's challenges and linkages. And the light just went off in the office, sorry. Um, and and then there's just restricted access to a lot of this data, which is very difficult. Okay, so for some quick analytical approaches to consider, and again, I'm happy to talk about any of these in more detail, thinking about traditional spatial analyses, thinking about spatial patterns and relationships. There's a lot of different options there with GIS mapping, hotspots, geographically weighted regressions. You can look for a spatial temporal analysis, thinking about tracking the evolution of some of these disparities and looking at emerging hotspots. And then multi-level modeling is another approach, right? So this is a nested structure of data, thinking about people in hospitals and counties and states, right? Um, and then proximity is always a very important area to consider. How are we thinking about distance or time to care? Are we thinking straight line, or is it the road network? Is it network travel time, or is it the catchment area of the providers? So there's a lot of different considerations to consider when pursuing all of this, which is something that is leading me to sort of the next steps, right? So thinking beyond just classifying as rural, clearly there are issues relating to all of these components, but some of the things I'm thinking about in terms of measurement innovation, then, obviously needing some multi-level modeling and spatial considerations. And then we have to think about how we're going to develop interventions around this and how it can actually be modified, right, to make changes, and then how things are best implemented. I'm just going to talk for a few minutes about my sort of next thoughts and next steps about measurement innovation for some of these geographic considerations. And then we should have plenty of time for questions. So this is sort of my next current thought process. I'm thinking about how we are very limited in the current geographic indices. A lot of the studies that I was looking at used some of these metrics like the ADI, the Social Vulnerability Index, these county health rankings. A lot of difficulty in terms of utilizing them and just the lack of clarity. And then obviously the fact that the rural designation didn't really help that much in terms of characterizing cancer mortality. So, and there's a lot of inconsistent use across studies. We see them used a lot in cancer studies, and it makes it hard to create some sort of comprehensive finding. None of these studies really capture community resiliency factors, right? They don't capture any of these protective factors, or they don't characterize them as such, right? Everything is formed in the risk context. They don't capture spatial autocorrelation. None of them have any sort of spatial weighting to account for counties that are closer to another. And they largely omit cancer relevant factors in a lot of cases. So thinking about an oncology healthcare workforce, NCI center availability, environmental exposures, or screening patterns in the population. So with that in mind, and none of them are rigorously evaluated, right? We don't see a lot of measurement techniques on them to really validate them at all versus in the cancer population specifically. So I'm thinking about a cancer-specific geographic index, right? So where are we going from there? So it would provide a standardized, comparable score and then contain actionable domain profiles, right? So to provide actionable information. And what would it enable, right? We think about targeting, prioritization. It would allow for intervention design and adaptation based on a specific index and some of these individual domains. It would allow us to monitor change over time because it would be reproducible. And then potentially thinking about healthcare performance comparison, right? So if hospitals are more fairly judged based on the areas and the resources that they have control, like that, they're in, it may allow for better performance adjustment. And then largely for your research utility, it's an open metric and thinking about it as harmonizing a lot of these geographic risk across data sets. So what I'm thinking is of developing an index using national data sets and then doing it in a spatially weighted approach, right, to quantify county risk and resilience. And then to look at it from, validate it in a very rigorous way, thinking about content validity with experts, and then thinking about convergent known groups and predictive validity. So using a lot of quantitative approaches to validate the metric against other indices and then within cohorts. And then finally, how are we going to operationalize and disseminate it and do it in a public way that's very transparent so that people can see the methodologies that are used? When we think about, it's a little tricky to think about conceptualizing a geographic index, right? As I'm thinking about some of these other, like the ADI, the SVI. And then for cancer, we have all of these frameworks. So we have Yabrov's that kind of mimics the socio-ecological model, right? Thinking about the layers from the individual level up to the policy and environment. Whitney Zand has the framework that models urban-rural disparities, but it starts from, again, from the individual level all the way up through policies and systems. And then same with Alcaraz, circling back to the beginning, right? So we have sort of these like structural inequities at the top, going down to everything affecting the cancer continuum at the individual level. So this county level index kind of requires a conceptual shift in your brain, right? That we're not looking at individual risk, we're looking at the health of the system, right? Of that ecological space. Like, what is the health of that system? And then in our case, we're looking at it at the county level. So we're thinking about two types of ecological effects. Compositional, so who lives in this county or who lives in this area? What are the aggregate population characteristics? And then contextual effects. So what is it like to live there? What are the features of the place that the person lives in? So this is what my thoughts are to pursue a methodology that adapts the National Risk Index, which is actually a FEMA model to look at natural hazards. And what it does is an online tool, and it shows all the US counties, and it does it also by census tracts, and at the greatest risk for 18 different natural hazards. And it measures risk and hazard loss, and then also combined with a measure of protective factors and resiliency for how well the county could potentially cope with the natural hazard. So the important part of this is that it's a framework that separates loss from the potential modifying factors. So it creates this sort of two-sided, dual-sided model. So in this adaptation, it'd modify it, so thinking about doing it over 5-year intervals from 2005 to what's most recently available. And what it includes is an expected loss. So you use your historical loss. So what is the expected cancer mortality rate proportional to the total list, right? So incidence, expected mortality rate, and then the historic loss, what has been happening in the past. And then what is the community risk factor? So it's the community risk factor is that ratio that I was talking about, that dual side. So it would be a measure of social vulnerability divided by a measure of community resilience. So what are the protective factors? And then the final score is a combination of those two. And then within social vulnerability and the community resilience are these subdomains that contribute to both, right? So this is sort of a model to kind of think about the individual domains that might be considered. Measures of resilience, and each of these domains has components of risk and resilience, right? So there's factors within each that contribute to risk and those that will inflate the resiliency and help with the protection. And right now I have about 45 risk measures and 40 resilience measures. So a little bit of an equal balance of the two. I'm kind of conceptualizing those. So how would I select these items, right? And they would be individually selected for both risk and resilience. And the first primary method would be a geographically weighted principal components analysis to allow us to kind of whittle down these items to use a quantitative approach. And it would also weight them by their account for space, right? And it's an unsupervised approach, meaning that the outcome is not included in these models, right? It helps to learn the patterns and the weights from the inputs only, which is good. This is how we would want to use it as an exposure index. And then as a sensitivity, I would pursue a geographic random forest, which is sort of a complementary approach. It kind of starts leaning towards that machine learning side of things, but it would more so be to look at the identify feature importance. So those most important characteristics that are emerging. It does include the outcome in the model, so it's considered a supervised approach. So you wouldn't want it to set the weights for each of the domains, right? But it can help sort of back up what your findings are of the initial GWPCA. And then as a validation strategy, using a stakeholder panel for content validity, and then for convergent validity, comparing the CCMI with all of the existing indices, right? So looking at correlations with ADI, county health rankings, and the social vulnerability index, and then looking at it across established cutoffs. And then for known groups validity, you can do, we'd be able to compare it across census regions, designations like Appalachian Delta. So what would we expect, right? And then across the rurality continuum. So how is it performing relative to what we would think? Is it able to distinguish between these groups? And then finally, just overall model performance, right? Using some of these standardized approaches. And then for predictive validity, I'll talk a little bit more about this. We test it in real world and synthetic cohorts. So how would researchers actually employ this, and how would it look in their real world cohorts? And so I'll be using it in the regards cohort, and then Smitha has so graciously agreed to be a part and allow me to test it on the BMTSS cohort, which many of you are all familiar. And then also creating a semi-synthetic cohort that is designed to be representative of the US population. Don't ask me too many questions about that. That's why I'm hiring a computer scientist to develop it. So I only have limited details on that one. Just to talk a little bit more about the real world cohort validation. So we do it in the regards cohort, which is what many of you are familiar with, about 30,000 individuals. Right now, it's actually up to about 5,000 incident invasive cancer cases. We have it linked to about 30 state cancer registry studies, and it has a good overrepresentation of rural population. And then the BMTSS cohort has blood or marrow transplantation patients, and they've had a long-term follow-up. And as of our last check-in, we had about a little over 3,000 adults that would meet the criteria for this particular study. And again, we would apply it as someone just applying a research question within these cohorts to see how it performed. And to do that, and then the synthetic cohort validation, basically county by county, creating a 100,000 person agent-based cohort where we use local demographic information. So we supply the county level information and basically create a cohort of patients relatively representative of the US population. And then we'd add realistic imperfections to help mirror the real world data challenges. And then to do this sort of predictive validity approach, the way I'm envisioning it is thinking about like a base model, and then adding in some of this patient-reported information that we get from the first two cohorts, not from the synthetic, and then adding the comparators in, and then adding the CMI and CCMI, and seeing how much it can contribute individually to that. And then also we'd be able to test the individual domains. And then thinking about public access and implementation. So creating a website, right? Having it being able to have being developed to have data that is sort of scraped and pulled in, and then having it integrated with code so that people can have regular updates, that it can have different versions, that it can be adaptable. And then having it to be have files that are exportable that people can pull and merge with their own data. And then we'd also engage stakeholders to pilot test this and make sure that the data is useful, and then publicly release. And how is this useful, right? Like another index. I'm thinking about it in terms of a lot of state health programs actually already use geographic information to guide their program allocation. There's a lot of examples in Ohio, Maine, New Jersey, New York, where they use different geographic indices to help guide resources for cardiovascular diseases. A lot of them for mammography. There's some for cancer screening information. So these could be helpful in terms of targeting resources. Thinking about hospitals and community needs. Nonprofit hospitals have to conduct needs assessments every 3 years. This could be a useful component to that. Thinking about population health models that are being brought in by CMS right now. Thinking about CMS Ahead model and others that it could help with benchmark and guiding allocation. Thinking about workforce targeting, advocating for resources, and influencing things like the National Health Service Corps placements, which is your loan repayment program. And then finally, my personal interest right now is this sort of idea of case mix adjustment, is how can these be used to create more equitable, accurate comparison in some of these performance models where people are, hospitals are trying to deal with, one, just general reimbursement rates, but then all of these CMS mandates that are coming out that are going to start, whether hospital systems like it or not, they're being brought into these sort of required models of care. So maybe it might be an interesting a way to adjust and provide more accurate payment reform. So yeah, so back to my research agenda, that's the measurement innovation piece, and then moving to the multi-level modeling, especially with my new role here, I'll do a lot more with the integrating the patient-reported outcome space, which is a lot of where I started, but pulling a lot more of that information back in addition to a lot of this geographic information, so it kind of all marries together, thinking about where people live and then what are their own personal responses, right? So what is the information coming from the patient, and how is this all going to contribute together? For the next steps. And then thinking about what to do with this next, right? Like how is it going to guide our interventions? And then how are we going to best implement? So that's all I have for today. I think we have about 10 minutes for questions. Hopefully that's enough. A lot of this was done at UAB, so I'm very appreciative. Thanks again for letting me talk, and I'm happy to take any questions.
Kelly, thank you so much. That was a fantastic presentation.
Thank you.
And I have a question. I think other people have questions. I'll let others go first. It looks like Christy has some urgent question happening. Is that right?
I didn't even have my hand raised.
Oh, sorry. Just like
I
so.
do have a couple of questions though. Kelly, this is lovely work. It's really cool to see how you're advancing the measurement methodology in this area. I wanted to point you to a grant that a collaborator of mine just got approved that I think has some overlap.
Mhm.
Um, she's a geographer who's trying to measure cancer care shortage areas, and I think is also kind of trying to think about not just geographic things, but also cancer incidence and
Yeah.
availability of providers, et cetera, et cetera. But one thing that I think is novel is this concept of resilience measures.
Mhm.
Um, I really would love to kind of see under the hood and see, have an understanding of like what are those things. And then I was also curious if you were using or considering using any like qualitative community-based methodologies to find more of those or figure out which ones should be included on your list.
Yeah, so I think so some of the ones we have now, so I should say for this first approach, I don't have any qualitative components pulled in at this point, but I do think that that is probably where this is headed at some point. You know what I mean? Like I think there's largely going to have to be some sort of qualitative component. Now the question is, how do you do that at a US population level? Like how do you figure out what that looks like? So some of the resiliency things we're thinking about are some of the protective components that are like thinking about, let's think about health factors and the health behaviors in the community, right? So what is the average rates of even flu vaccines? How often are people getting mammographies, colonoscopies? There's some evidence that civic engagement, thinking about density of nonprofit facilities, access to broadband internet. So those are considered, those would be starting to lean towards like resiliency and protective factors. And also, again, framing some of the healthcare access pieces not as negatives, but as positives, right? So the way some of these other indices bring them in, actually, many of them don't bring in the healthcare parts at all, but it's sort of like lack of, but in this case, we would think of NCI facility, number of radiation oncologists, number of surgeons, number of like they would be in terms of those would be protective. So higher numbers. So both sides would be scored that higher numbers are better, if that makes sense. So that's how we would sort of frame that. And thank you
Great.
for the pointing me to that. That would be super helpful to see what they're doing.
Yeah, I mean, I think there's some similarities to what you all are trying to
Mhm.
do, but I do think the like idea, the concept of protective factors would be novel, and it sounds like this would be broader reaching. But Joshua Richmond actually was the one who pointed me to this sort of concept of, oh, maybe having a cancer center in your area is matters not just to the people who get care there, but to the other people in the area. And so it's like
Yeah.
something we're kind of interested in studying, and I put out some papers on recently. And I think that's like one of those resiliency factors that,
Yes.
maybe not measured that well right now.
Yeah.
Other questions? So while we're waiting for someone else to have a question, I will ask you mine. So I was really wondering, and maybe I missed this, but do you have the cause of death? So the increased mortality in the rural populations, do you know the cause in terms of whether it's treatment-related complications versus disease progression? I'm thinking, access in the rural areas to when they have a complication, is that lead to their demise?
Yeah, so in all of those, it's all just cancer. We don't know, it's just, it doesn't have, it does not distinguish between treatment related versus not. So where I think it can be considered, I don't know whether it's treatment related or not, but in one of the studies with the breast cancer, when almost more of the risk was accounted for by specialists,
Mhm.
for the stage 4. That to me speaks to that they're having issue, like that their demise is brought on by continued treatment and decline and other factors. But no, those databases do not allow you to determine whether it's treatment related or not in that.
Okay, and that's really interesting,
Yeah,
if there's a way to drill down
yeah,
on that,
yeah. I
because it
think in
kind of
some of the
relates.
resources I have now, probably, but
Yeah, it probably relates to the point you made about, I think one of your colleagues is looking into, discharge care, or is
mhm,
that something
yep,
you're planning?
yeah, yeah,
Because that might relate to, so patients, especially during that acute phase where they're getting treatment and knowing when to access care for complications before they become severe.
yep.
Is that part of that program?
So that, yeah, this is all of that is underneath the current R is, so that's she's a surgical resident at BMC that's working on all of this. She's really interested in what happens after people leave. And yes, that is, she's actually very much trying to untangle exactly what the causes are of that may not necessarily be defined in, we're using proxies, right? So we're pulling information to kind of infer as to why people are either being discharged to a certain place and then how they're ending up being rehospitalized and all of that. That's as best we can do from claims, right? But all of this is going to have like pulling from larger AHR, which I think I'll be able to kind of go towards now. So that will be able to supplement it. But in all of this, it's all been proxy and inferred. But yes, she's going down that route of finding that the underlying reason as to why.
That sounds fascinating. I'm really interested in how that comes out.
Thanks.
Noah, did you have a question?
Yeah, so well, first of all, wonderful work as expected, and I'm so excited to see how you're moving all of this forward. This might sound like more of a general high level, non-expert question, but the index that you're developing, it has like the cancer specific mortality index. Did I get it right?
Close.
Yeah. Okay. So how do you see that applicable to other outcomes other than mortality? Like, and how would that, for example, when I think for other outcomes from a survivorship lens, and I think of the other established indices, ABI, ASBI, as you mentioned, how do you see yours also performing with other outcomes other than mortality?
I completely agree. And I think that I don't necessarily know how it will perform until I can validate it in mortality and then test it in these other cohorts with other outcomes. I truly don't know. Like, I think there is a degree of it, maybe it does not, maybe the mortality piece makes it almost more of a brute force. Does that make sense? And it may not be sensitive enough to pick up these others. And then maybe there's alternate items. So this is where you then change the index, right? You can revalidate it based on other outcomes, right? So then you take your same set of items and you reorient it to being, okay, treatment discontinuation due to toxicity. You reorient it towards other things. I think that the mortality piece is going to be your strongest, you know what I mean? Like your most blunt instrument. And then from there, you can probably pair it, like it's going to have to be reoperationalized to target others. But I think the only way to do that is to start with one and then to test in cohorts where that information is available. Because as
Right.
of right now, all we can test first at a national level is mortality.
Right.
So, but yes, no, I agree. I do think that it would be interesting, and I wish I could say I would not be the one to say I think it'd be performed perfectly. It would tell you exactly that someone would
Yep.
discontinue treatment or would have toxicity or would not be adherent to care or you know what I mean? Like I did, but I think you can use the same approach, and I think you can use a same set to then tailor for others.
So that's where we're gonna come in and start working together once you're done.
Yes.
There you
Perfect.
go.
Okay, looks like we have time for one more question if anyone has. Okay, well, Kelly, thank you so much. This was so enlightening, and congratulations on your recent new adventure. And we look forward to seeing lots more from you in the future.
All right, thank you so much.
Thank you.
Glad
It's
to
great to
see
see
you.
you.